Good morning, everyone. This is Marcelo Agostino from the Pan American Health Organization. We want to welcome all of you. We have a big number of people, more than 1,300 people registered for this webinar that we are organizing in collaboration with the Inter-American Development Bank. So thank you so much for being with us. As you can see in the screen, I will make some general announcement before starting. As you can see, we will use Slido, so you can go direct to this URL, slido.com, or you can download the app in any Google Play or App Store. The code for this session will be the 3694. And the idea, if you can go now, is to see which region are you connected from. So I will switch to Spanish just because part of the announcement that we want to make is that we have you can see in the Zoom platform that there is an icon for interpretation, so you can select either English or Spanish. The main language of the session will be in English, but we do have also questions and interaction in Spanish, but we cover everything with simultaneous interpretation. So, muy buenos días, muchas gracias por conectarse. Tenemos un número muy grande de personas registradas, cerca de 1.300 personas. Les damos la bienvenida. Soy Marcelo D'Agostino de la Organización Panamericana de la Salud. Y estamos organizando este evento en coordinación con el Banco Interamericano de Desarrollo. Estaremos utilizando Slido para interactuar y si pueden utilizarlo tanto desde un navegador, slido.com, como desde alguna aplicación. I will not share for you also to be aware of the people. We have here different, you can see this dynamic screen. You can see from where we have people connected to the session. So we have, I have the pleasure also to share with you that we have our panelists from the Harvard Medical School, from the government of the city of Buenos Aires, from the Inter-American Development Bank, and from our headquarters office, the World Health Organization in Geneva. And our special guest, the keynote speaker, is Dr. Espinal, to whom I will make an introduction later. So without further ado, and thank you very much for interacting on Slido, that will be open for a couple of minutes. Because we want to also not just to see from where you are connected, but also to understand the different dynamic of the meeting and future actions that we are planning to do on artificial intelligence and public health. So I'm glad also to introduce right now to Natalia Alarcón, who is a co-moderator with us. She is from the Inter-American Development Bank, who will run the next part of the meeting. So I will stop sharing and I will pass the floor to Natalia. Thank you so much.
Thank you, Marcelo, and good morning, everyone. I am happy to be here today, and I would like to thank the audience for being connected today. I can assure you that the conversation looks very promising. So let me welcome, and to start, let me welcome and give the floor to Dr. Sebastián García Saizón, who is the director of the Department of Evidence and Intelligence for Action in Health at the Pan American Health Organization. So welcome, Dr. Garcia, and thank you for joining us today. Over to you.
Thank you very much. Let me just take a couple of minutes to open this very important webinar today. Good morning, everyone. Hope you are all keeping safe, considering the current circumstances. And I'm happy to see so many of you that are actually joining and participating in our seminars that intend to be a path towards a better response, not only for COVID-19, but overall the health needs of our populations with a focus on the use of appropriate technologies. It is a pleasure to be here again with you, sharing once again the organization of this seminar series with our partner, the Inter-American Development Bank. I want to express my sincere gratitude for this amazing collaboration between PAHO and the IADB on information systems and digital health in the Americas. We're sure that the path in front of us is full of opportunities and ways to have a greater impact in the region. We're also very excited about PAHO to open this third webinar called COVID-19, Artificial Intelligence Towards the Digital Transformation of the Health Sector. I want to highlight the presence of our panelists from our headquarters in Geneva, from the Harvard Medical School, from the IADB, and from the government and the city of Buenos Aires. As you may know, this is part of the series Share, Listen, Act, COVID-19, the potential of digital health and information systems for health in the fight against the pandemic. And today's objective is to debate with and learn from experts, international organizations, and academic institutions on the opportunities and challenges in the response to the pandemic presented by artificial intelligence. Artificial intelligence, which in reality is not a new area, could without a doubt add value to health systems as never before. Not only in the response to the pandemic, but to the strengthening of the health systems in the post-pandemic stage also. However, we need to consider all of this in the context of digital transformation of the health sector as a whole, and not just as isolated applications using artificial intelligence algorithms or fancy applications. Currently, at the Pan American Health Organization, in collaboration with the IADB and other partners, we are working hard for having a new framework on artificial intelligence and public health, a people-centered and ethically grounded model for improving public health in the Americas. This framework is based on international human rights principles, PAHO, and WHO values of equity, excellence, solidarity, respect, and integrity, and in compliance with PAHO's commitment to provide technical cooperation to its member countries to strengthen health systems and response to emergencies and disasters. And we are very excited today, as without any doubt, we will learn a lot from our panelists and from all of you. And therefore, we'll be able to make this framework even more solid. Finally, I want to personally thank our keynote speaker, Dr. Marcos Espinal. Good morning, Marcos. Welcome and thank you very much. Marcos is PAHO's Director for Communicable Diseases and Environmental Determinants of Health, and one of the spokespersons for PAHO's response to the pandemic. So, without further ado, I want to welcome you all to today's seminar and thank the Pan American Health Organization and the IADB teams that have put this seminar together and make it possible for all of us to contribute and to share our knowledge and experience to this great task. Thank you all. Good morning, and I wish you all the best. Thank you, Marcelo, and over to you now.
Thank you, Dr. Garcia. Thank you for your words and your insightful insights. So as you move to the keynote presentation, let me give it back to you, Marcelo.
Thank you very much, Natalia. Thank you very much, Sebastian. I forgot to mention something important. I am part of the Department of Evidence and Intelligence for Action in Health. So Sebastian is my boss. Thank you so much for the welcome remarks and opening remarks. I'm very happy also now to introduce Dr. Espinal. And thank you so much for your time and also for your insight, Marcos, because we know that being the spokesperson of the Pan American Health Organization is a huge issue. We know that some minutes before this session, you were on CNN. Marcos is also the person who was in charge and connected with previous public health emergencies and the head of communicable diseases. So he was involved in H1N1 and everything that is part of the history, and one of the mentors and creators of a global initiative that is very robust initiative called Stop TB. So thank you very much, Marcos. I can if we need to present your bio, we can take 30 or 1 hour. So I will stop here and pass the floor to you, Marcus, for the keynote. Thanks. You're in mute, Marcus.
You're in mute, yeah.
That's the most popular sentence nowadays.
Yeah. Can you hear me now?
Yes, perfect.
Okay. Yeah, exactly. We tend to think that we know that we are not mute versus unmute. Good morning, everyone. Thank you very much, Sebastian, Marcelo, for the invitation, and to the IADB, which is a great partner of PAHO. You know, I have the pleasure of working with Ferdinando Regalia for many years now, and several initiatives, not only now. I'm very pleased to hear that, you know, PAHO is collaborating with IADB on information systems for health, but also IADB has collaborated very strongly with us in malaria, NTDs, and other areas, important areas of work of public health problems that, you know, affect our region. It is a pleasure to be with you, and hopefully in my 20 minutes I can give you, Marcelo asked me and Sebastian asked me to give you an overview of the situation of COVID, where we are now. And I hope to be able to give you some good information that you could use to talk about artificial intelligence and information systems. It's artificial intelligence is a very exciting field. I was just reading a few days ago about how engaged, you know, in long, you know, great institutions like MIT, you know, the Lawrence Laboratory, Berkeley, are very well engaged in areas and in the field of AI and COVID. And one of the things that struck me is the number of articles that has been published, you know, about COVID is thousands and thousands, and now there are initiatives that, you know, based on algorithms and languages, you know, that you could easily get faster articles about COVID depending on the topic and so on, but also, you know, initiatives such as, you know, what is the best material for the face mask? How do we deal with all these tests, rapid testing that are out? And sometimes some of them are not good, some of them are very good. So exciting times. And I think information system and will benefit a lot, because historical information system is not an attractive topic for governments and so, but it is changing now. And thanks to PAHO and IADB joint forces, our region could boost these efforts. But let me go to the task at hand. I'm not going to bring slides. I'm going to bring, you know, few remarks. 6 months now, and we entering into a protracted emergency, and take into account that term, protracted emergency, because the management might have to be a little bit different after some time. Overall, just now we passed 15 million people affected, amazing, and 600,000 death, and 216 countries, territories, and areas affected by COVID. And you probably know this. So no one is spared from this pandemic. This is a true pandemic. This is really a major public health crisis. Globally, the top countries, the US leading with 4 million cases, Brazil with 2 million cases, then a little bit more, India, 1.3, Russia, big countries, you know, vastly populated. That is important. When you look at the number of cases by absolute numbers or by rates, it makes a difference also. South Africa with almost 400,000 cases, and Africa is a big challenge because it's now, you know, remember this started in China and other parts of Asia, and then slowly moved to Europe, after to Latin America, and now it's slowly impacting Africa, where poverty is a huge issue. Peru, Mexico, and Chile are among the top 10 in the world. So our region has been the most affected. Of the 50 million cases, half of them are from the Americas. So it is critical, and that's a message, one of the messages, that we cannot let down our efforts yet, because we're still seeing huge number of cases in the region of the Americas. In terms of mortality, you know, I spoke about 600,000, US with about 140,000 deaths, then followed by Brazil with 80,000 deaths, UK 45,000, Mexico 41,000, and Italy, France, India. These are the top 10 countries. So, and that's the sad news, because the most important issue here in COVID is how we work together to accelerate tools that can help us to prevent mortality. Because if we're saying, and we know that now, that 80% of the cases are mild or moderate, then we are basically saying that our top priority should be preventing death. And this is critical that we focus on that. Preventing transmission also to you know, it's important, because if we prevent transmission and we cut the chain of transmission, then we are contributing to reduce death also. And I'm going to talk a little bit later about the measures that needs to be implemented. Probably most of you know. One important issue to say is, epidemiologically, there is not much difference between male, female. It's about 50-50 both. So it doesn't respect anybody, but it also doesn't respect age. Although now we are seeing that the highest number of cases is in working classes, in people between 20 and 59 years of age. These are the people who produce for our economies. Mortality, on the other hand, is higher in people of 70 years of age, which are also people who has other conditions. And we know that there are several conditions that increase the likelihood of mortality. Thus, then this is why prevention is important, and protection of our elders and our grandparents, our uncles, our aunts, the senior people in our countries, people who work for us and who are responsible for giving us where we are today, our parents, our families. And this is why it's important to the youngsters: protect your people, protect yourself. Because if you go to the beach to celebrate, if you go to the party to celebrate, or to the bars, you might be contributing to the death of your relative. And we have seen that. You know, it's sad to say this, but that's the evidence. And these conditions are basically pretty much diabetes, cardiovascular diseases, respiratory diseases, and so on. It is critical that the actions heading to mitigate and slowing this pandemic are implemented. Remember, it did affect the Prime Minister of the UK. It has affected the President of Brazil. It has affected the President of Honduras. It doesn't respect color of the skin. It doesn't respect political boundaries. It doesn't respect anybody. So this is And it's a major lesson for me, for the policymakers and leaders of our region, that investment in health should be a top priority, but not for the moment, should be sustained and increasingly every year. PAHO, for instance, recommend that our countries invest at least 6% of the GDP as public health investment in health. But still in our region and in many other countries of the world, they are not yet there. So it is vital our leaders see this as a lesson that health and education are the ones that develop countries and protect us and create to empower and to create the new generations and healthy people and so on. So important, we know that this pandemic, we don't have medicines, we don't have vaccines, and we know there is a race now to develop new vaccines, 160 vaccines today in preclinical and clinical stages. But remember, only 7% of the vaccines in preclinical testing make it to the next phase. That's the evidence of vaccines. And when they go into clinical, not preclinical, if they pass from preclinical to clinical, the rate is 15–20%. So not all these 160 vaccines will be able to make it. It's important. You know, and we've been hearing about the Oxford vaccine and another vaccine in Massachusetts and so on. But hang on, we still have a long way to go, at least next year, because after the vaccines, the scientists and the academic institutions are, you know, publish the results that it works, then, and just say, you know, those vaccines are in early stages of clinical testing. It's not yet, they are yet advanced. But after, we have to license the vaccine, we have to manufacture, and we have to insert the vaccine in the immunization programs. So it's a long way to go. But, you know, the work is working to ensure equitable access to vaccines to all the countries of the world through the WHO, Gavi, CEPI initiative called COVAX, where every country will receive 20% vaccines for 20% of the population, mainly the high-risk people, healthcare workers, and senior people, and then we'll receive the others. But the idea is that every country receive the first batch of vaccines when they are available, 20% for the 20% of the population, the one that are mostly at risk. And 160 countries has committed to this initiative. So there's no doubt it's going to get, but we need to wait for the scientists to tell us it's ready and then manufacture it. In the meantime, we need to ensure we implement actions or measures that are aiming to mitigate or slow the advance of this pandemic. You know, there's two types of main measures. Containment measures and mitigation measures. Containment measures basically are, and these all measures are based on the International Health Regulation, which is a binding treaty that the countries of the world signed in 2005. And this treaty suggests the countries to implement about 14, 15, 17 core capacities, or call it essential public health function, on how to respond to viruses, to outbreaks, how to prepare for outbreaks, how to prepare points of entry, airports, ports, how to strengthen surveillance, laboratory testing, risk communication, and it's a package. So these measures, while we wait for the medicines and the vaccines, needs to be implemented because they contribute to flatten the curve. And we have seen that, you know, initially in New Zealand, Australia, Europe is pretty much flattened, but we are observing now new peaks in Europe and in other countries. So this virus is very unpredictable. Please remember, we don't even have a calendar year with this virus. We're still learning. And for this region and other parts of the world, winter is coming. Like in a famous TV series, we used to say, winter is coming. So we'll have the flu plus COVID. But it's not only COVID. We also have other diseases to take care of, dengue, TB, malaria. So it is critical when governments implement these measures on, risk communication, on isolation, detection, capacity of the laboratories. It is critical. They secure also the supply chain for food, the supply chain for medicines and health services for other issues. We have also diabetes, cardiovascular diseases. So it's not only COVID, but COVID is the attention now. And entering into a protracted emergency, it is very important. Health services will become, because they are the backbone of the response. If we don't prepare these health services and make sure they are able to respond to this by having the number of beds available, the laboratory testing available, the medicines when they come available, and the vaccines, because if we are saying that 80% of the cases are mild or moderate, they don't need to be hospitalized. In a long-term protracted emergency, the first level of care are the ones that are going to be taking care of this pandemic. It doesn't have to be big specialized hospitals. So it is important to take these things into account. At the same time, when this epidemic goes down, we need to continue strengthening those capacities of the international health regulation, because, ladies and gentlemen, this is not going to be the last outbreak. Please don't forget Ebola in West Africa. Please don't, more than 20 outbreaks of Ebola in Africa historically. Please don't forget H1N1, don't forget Zika virus. So we need to continue strengthening those and not to forget. And I go back to my investment in health comments. PAHO has been helping countries, with technical cooperation in our region, and WHO also globally. By helping to set coordination mechanisms, multi-sectorial mechanisms to coordinate, delivering personal protective equipment, capacity training, for setting laboratories, decentralizing laboratory testing, because these are, WHO and PAHO are organizations that belongs to the countries. And we hear criticisms and things like that, but the fact is that an organization with more than 190 countries, members, we need to hear all of them. We need to be able to, we need to work for all of them, and we do work for all of them. So technical cooperation is critical, but this is going to be a long-term issue. And something important to our leaders, let's not politicize this. It doesn't respect politics and boundaries. That's important. And I finished with some of the challenges to make my 20 minutes and don't steal time for the panelists. I mentioned no vaccines, no medicines except remdesivir, which is a medicine antiviral that it doesn't even, it helps, but it's not the real, it's not the medicine that we're looking for. But it does help, shrinking the time in hospitals and so on, reducing a little bit mortality. Dexamethasone also is as promising, but still some way to go. I think the future will, governments need to continue the social protection programs for many our people. Remember, in the Americas, Africa, huge poverty issues. In the Americas, inequities, probably the highest region, the highest in terms of inequities. Huge informal economy in our countries. So it's not easy to implement social distance, you know, but we need to try. We need to try. So, and minimize the impact of this pandemic. I think managing this as a protracted emergency, ensuring health systems are able to cope, monitoring the use of our hospital beds, IC, intensive care units, decentralizing laboratory testing to make sure it's accessible to everyone. You know, we have said that this is not only a public health crisis. This is a confluence of public health, social, and economic crisis. Because a father, we can understand a father with 2 kids living in a barrio of Santo Domingo or Mexico City, or, you know, in a crowded population in Asia, because the problem in Asia, demographic explosion and things, it's not easy for them to implement social distancing. Access to water and sanitation. If we don't have access to water, then how can we wash our hands? So I think it's important moving forward that the international community continues supporting, technical agencies continue advising the countries, ensuring that the people are protected. Social packages is important, finance packages are important also. And when the vaccine comes, we all work together to make sure, and we are working, to make sure it is accessible to everyone in equitable fashion or way. Education is very important. We need to continue educating our people because perception is also important. And this is why I say let's not politicize this, because it's a public health issue and life is precious. I pause here. I thank you for your time. Sorry if I bore you. And if there is any question or comments, I'm happy to. I might have to leave because I have several other commitments in line, but I have a few more minutes, so I thank you for your time. I don't know if my time was okay. I didn't want it to be up after 20 more minutes. Thank you very much.
Thank you very much, Marcos. And thanks a lot for giving us the context. The idea was exactly that, because something that happens in the, let's say, in the cycles of artificial intelligence and technologies, one of the biggest problems was always the lack of connection with the public health context. So we had in the past people working on applications, on technologies, and in other sides, people working on the strengthening of health systems and response. And this is why now there is a clear message across the planet on the importance of digital health solution, but this is something that was on the agenda for the last 30 years. That there is a very important paper and a research about the cycle reincarnation of artificial intelligence that started more than 30 years ago. And one of the conclusions of the researchers is that, in particular, the lack of connection with public health interventions, etc. So the idea was, thank you very much, Marcos. It will be impossible to answer all the questions, in particular questions that are not related to the main core element of the webinar, but our commitment, as we did in the previous webinar, is that we will produce a report with the answers. So we will go now because people are eager to start the debate under the context presented by Dr. Espinal on how artificial intelligence can support what are the challenges. So right now, but under the context of the response, social and economic situations, public health interventions, relations with non-traditional partners, development partners, etc. So I will pass the floor now to Natalia. Thanks again, Marcos. And we understand that if you need to run to another commitments, you already mentioned that in advance. And then we will organize a separate session to discuss the questions of the people and the best way to publish that into the meeting report that we will prepare with IADB. So Natalia, the floor is yours. Oh, Marcos. Marcos, I'm sorry, you took the...
Yeah, we'd be happy to give you answer for some of the question in writing later on if you want to, Marcelo.
Okay, thank you. Thank you very much, Marcos. Thanks.
Thank you.
So thank you, Marcelo, and thank you, Dr. Espinal, for the good overview of the current situation. And yeah, I mean, from that, we will explore a little bit more on how emergent technologies and especially artificial intelligence can actually help to address those issues and those challenges that you mentioned in your presentation. So can artificial intelligence help to detect or prevent or better respond to the current crisis? That's part of the debate that we want to have in our panel. So with that in mind, and before going to our panelists, I would like you, the audience, to invite you to participate in our online poll on our Slido channel. So to participate, you just want to go, please go to slido.com. And when prompted, you need to enter the access code that is 3694. And you can join us in answering the question that we have for today. So the question related to our topic today is, what do you think are the areas of AI that can help more in the fight against COVID-19? So please take your time, vote, participate, and we will check the results at the end of the panel. So without further ado, let me start the panel by quickly presenting our great panelists for today's conversation. So first, we have with us Analía Baum, who is the Director of Information Systems and Digital Health in the city of Buenos Aires. So she's connected from Buenos Aires. Hi, Analía. Second, we also have Dr. Jagpreet Chhatwal, who is an assistant professor at the Harvard Medical School in Boston, Massachusetts. Doctor, I hope I correctly pronounced your name. Apologies if I didn't.
Oh, that's perfect.
Thank you. Great. Third, we have with us Luis Tejerina, who is a lead social protection specialist at the IADB, connected from Washington, D.C. Hi, Luis. And last but not least, Samir Pujari, who is the Senior Advisor on Digital Health at the World Health Organization in Geneva. So welcome, everyone, and thank you very much for being here today. So to get us started, let me switch to Spanish, because I want to start talking, starting the conversation with Analía. So, Analía, a partir de lo que nos contó el doctor Espinal y de esta situación y los problemas que estamos viviendo y que está enfrentando el sector de la salud pública, y dada tu experiencia en una ciudad como Buenos Aires con más de 3 millones de personas, ¿cómo crees o dónde crees que la inteligencia artificial puede hacer la diferencia o puede generar un cambio en la forma en que tomamos decisiones en salud pública?
Hola, buenos días a todos. Bueno, muchísimas gracias por la invitación. Es un placer estar en el webinar, y gracias también a los organizadores que me dejan expresar en español. Me siento más confortable para expresar mis ideas y compartir la experiencia. Me parece, digamos, muy importante retomar algunas palabras que dijo el doctor Espinal con respecto a que las herramientas de inteligencia artificial van encaminadas hacia prevenir la muerte, y en el caso de la pandemia, prevenir la transmisión. Pero digamos, yo les quería contar un poco el contexto de la ciudad de Buenos Aires y encaminarme a la pregunta de dónde la inteligencia artificial podría hacer la diferencia. Entonces, si bien la ciudad de Buenos Aires es una ciudad que tiene 3 millones de habitantes y tiene más de 100 establecimientos sanitarios del sector público que brindan servicios, digamos, gratuitos a toda la población que pisa el territorio de la Ciudad de Buenos Aires. Estos 100 efectores se dividen un 30% en niveles de hospitalarios, o sea, de alta complejidad, y un 70% del primer nivel de atención. Pero es importante que conozca la audiencia que la Ciudad de Buenos Aires, de esos 3 millones, 1 millón es usuaria del sistema público, pero además la ciudad tiene durante el día aproximadamente entre 8 y 10 millones de personas que transitan la ciudad y que también, digamos, son usuarios del sistema público. Y de toda el área metropolitana tenemos aproximadamente unos 7 millones de personas que podrían ser potenciales usuarios del sistema público de la Ciudad de Buenos Aires. Entonces, lo que nos sucede frecuentemente es que lo que gestiona el sistema de salud es la oferta, la prestación de servicios, pero que lo que no podemos, digamos, gestionar es la satisfacción de la demanda de la población. ¿Y por qué traigo, digamos, esta introducción? Porque, digamos, yendo a la pregunta de dónde la inteligencia artificial podría ser la diferencia, claramente es como el doctor Espinal, digamos, lo introdujo, que es en prevenir, digamos, en prevenir la enfermedad. En este caso, en la pandemia, es prevenir, digamos, la transmisión, pero podríamos llevarlo a cualquier tipo de enfermedad infectocontagiosa que es prevalente, digamos, en nuestra región, como podría ser la tuberculosis. Y en ese sentido, la inteligencia artificial es poderosa, siempre y cuando, digamos, el gobierno, los estados tengan una estrategia sanitaria que vaya más allá de la prestación de servicios o del sistema de salud, porque sabemos que estas enfermedades infectocontagiosas y el COVID, digamos, no es diferente en ese sentido, sino, digamos, basta con mirar un poquito la incidencia de algunos países. Yo les puedo contar la Ciudad de Buenos Aires, pero es claramente afecta más en las áreas que son más vulnerables y que tienen, digamos, factores sociales, económicos, ambientales, de vivienda, de desempleo, que vinieron a mostrar, digamos, que esto es parte del problema sanitario, ¿no? Y que la salud es una cuestión de Estado y no solo una cuestión, digamos, de los médicos y del sistema de salud. Entonces, bueno, se puede ver en Estados Unidos en la incidencia de casos de Manhattan con respecto a Queens, que es, digamos, de 350 versus 1800, y en la ciudad de Buenos Aires no es distinto. Cuando uno mira los casos acumulados en los barrios vulnerables, es 7 veces más que en el resto de la ciudad de Buenos Aires. Y si yo, digamos, quisiera hacer un poquito, digamos, más incisiva en este tema, les podría hasta compartir algunos gráficos que están en una publicación que, digamos, que en este momento está en proceso de evaluación para publicarse, donde nosotros, si bien, digamos, cuando miramos la mortalidad en general, no vemos una diferencia, porque hicimos una regresión ajustada por edad, tomando las variables de aquellas personas que viven en barrios vulnerables versus no vulnerables, y claramente, digamos, si bien, digamos, comentamos que esta es una enfermedad que afecta a toda la población, claramente la incidencia de mortalidad de las personas más jóvenes que tienen, digamos, que tienen algunos determinantes sociales como los que les comenté, que viven en barrios vulnerables, digamos, la mortalidad es más alta en grupos etarios más jóvenes. Entonces, para mí, digamos, digamos, claramente el potencial que tiene inteligencia artificial es, para el Estado, los gobiernos, es integrar toda la fuente de datos de estas condiciones de empleo, de vivienda, de agua, de saneamiento, de educación, de empleabilidad, junto a las de salud, para poder, digamos, identificar qué personas podrían tener más riesgo de enfermedad y menor chance de acceder al sistema de salud, o como pasó ahora, digamos, menores posibilidades o condiciones de aislarse durante la pandemia, pero digo, no quiero hacer específicamente foco en COVID, porque me parece que COVID nos vino a mostrar esta problemática sanitaria que tenemos en general.
Buenísimo,
no sé, ya
Analía.
estoy en el tiempo de los 7 minutos y Luis quiere...
Ya estamos bien. Le quería justo pasar la palabra a Luis para que nos cuente él cómo ve el potencial de prevención que nombraste tú de la inteligencia artificial en este tipo de crisis, y tal vez no solo asociado al COVID, sino a otro tipo de enfermedades, como bien lo dijiste tú, Analía. Luis, si quieres comentar algo.
Sí, gracias, Analía. Me gustó mucho el enfoque que le diste a la participación, porque uno podría pensar, existen inversiones fijas que se tienen que hacer en generar bases de datos ordenadas de diferentes actores del Estado, generar esa interoperabilidad que te permita ver diferentes variables socioeconómicas que son determinantes de la salud, un mapa urbano que te diga dónde tienes condiciones que pueden ser determinantes para tener efectos negativos en la salud. Y si uno piensa solamente en COVID, podría pensar, no, tenemos que atender la emergencia y no construir cosas para el largo plazo que pueden ser muy costosas o pueden tardar mucho. Pero en realidad, la infraestructura, todo este andamiaje de datos, que es lo que sirve para entrenar algoritmos, puede servir para muchísimas otras cosas relacionadas con salud. Llegó COVID y nos agarró mal preparados porque tenemos en nuestra región cantidad de bases de datos, sistemas de heredados, con datos desordenados, que es muy difícil hacer que interoperen, que se articulen, que se hablen de la noche a la mañana. Pero comenzar ahora es un excelente inicio del camino. No creo que COVID no se va a ir mañana. No sé si se va a ir en un año o en 2, pero seguramente va a estar con nosotros por un buen tiempo, y seguramente vale la pena hacer estas inversiones para tener los datos ordenados que nos permitan tener diferentes mapas de vulnerabilidades, el análisis de imágenes cruzado con datos administrativos de diferentes zonas del Estado, y así hacer modelos predictivos a medida que vamos generando más y más información relacionada con COVID, que fue otro problema, ¿no? Que comenzó COVID y la inteligencia artificial no pudo entrar inmediatamente por la escasez de datos que existen sobre el tema. Entonces tuvo un comienzo muy lento.
Gracias, Luis. Voy a pasar a inglés nuevamente. So, thank you because Luis talked about a topic that is super important in this conversation, that is data. And that actually allows me to move to my next question to Dr. Jack. So Dr. Jack, based on your experience with the use of the COVID simulator in the USA, that actually would be great to hear from you a little bit more about the tool per se. So based on your experience, what do you think is the minimum set of data and also health workers' skills that countries should have to implement those AI solutions in an effective way in order to support the public health interventions in this fight against COVID-19? So data and skills.
Let me start with thanking Natalia for the introduction. I also like to thank the organizers and Sebastian and Marcelo for inviting me to this panel. And it was very fascinating to hear from our keynote speaker, Dr. Espinal, talk about very broad, high-level impact of data and use of artificial intelligence. We have been working on COVID since February, before even things started became pandemic in the United States. We started working on modeling, understanding the data needs. So I would like to share some of our experiences in the process and what challenges we have faced, what opportunities we have seen coming in this, which are very unique to COVID, and what we hope we can maintain moving forward. So first is the foremost ingredient for any modeling or any artificial intelligence tool is data. What we have seen in this situation is that there is unprecedented level of information sharing that has started happening. Data sharing has happened at a level which was not seen before COVID. To give you some examples, many for-profit companies, academic centers have started sharing data freely to anyone who is working on COVID or for other purposes who are affected by COVID. This is one area which has affected every sector of human life. So everybody has been touched by COVID at some level. So people have become very open to data sharing. Google, for example, they have made their mobility data publicly available. Anybody who wants to look at how people are moving from one location to another. Are they traveling? Are they going to parks? Are they doing groceries? All of that data are available at different levels, geographic levels. So this was not really the case before COVID. At least it was not well known how we can utilize those data sets. There are many other companies, similar other names, without naming all of them, they have made their data available. So that helps to people who are working on machine learning or modeling to inform some decisions. With our simulator, one of the things that we wanted to see was inform the timings of the interventions. Well, we have known by now that the timing is very critical. At this stage, unfortunately, all we can control is non-pharmaceutical interventions to a large extent. Should we open the economy? Should we lift restrictions? Should we close down certain geographic areas where we are expecting outbreaks? And the timing is very key. Like even 1 week can make a huge difference in the pandemic like this. Our tool and many other tools that researchers all across the world have developed have answered questions about the impacts of the timings of these interventions, which are driven by a lot of this data that's fed into the models. So that's one area where we have utilized how people are moving. If we can inhibit the movement of people, could that result into reduction in transmission in the community? So that was very helpful. Another area where, again, use of data is very helping us is the predicting outbreaks early on. If we suspect something is happening in the community right now, and if we can have early warning signs, like even like a few days in advance that there's an imminent outbreak in this particular city or county. So that can inform policymakers to act quickly. If there is a need to close schools, there is a need to close offices, or there is a need to close the entire city, and to what extent. This can be very helpful. Again, this has been happened because of, one, availability of data, and second, the use of artificial intelligence in predicting outbreaks. And the many, again, groups working in this area, again, from the academics as well as from the from industry. That has been helpful. Now, there are several challenges also that we face. And while there are certain applications of informing the timings of interventions, other things, if we pick certain situations like in mega cities, which are crowded, where the literacy level is low, people still have, many people are using smartphones, can we utilize the artificial intelligence to break community transmissions in crowded cities, like in New Delhi, mega city, it's 18 million population, others Sao Paulo, which has close to, I believe, 10 million people. So in cities, crowded cities, high density, a mix of demographics of population, how can artificial intelligence prevent outbreaks in those kinds of cities? I think it's one of the challenges that maybe we can help as a community answer some of those questions. And hopefully, as we move forward, we have vaccines, treatments, and we are beyond COVID. We would hope that and such level of transparency, data sharing, knowledge sharing continues in other disease areas. So that's the hope that we expect after COVID.
Thank you very much, Dr. Jack. And actually, I would like to highlight a point that you mentioned related to the availability of good data, So, and how this data can be used to prevent future outbreaks, and how it can be used to inform better the policymakers. So about that, I would like to ask Samir to comment on that, or what do you think is, from your perspective, the importance of data?
Thank you, Natalia, for the question. Let me first start by taking a moment to congratulate you and Marcelo on organizing this prodigious knowledge sharing panel. I think it's heartening to see so much interest on this topic. Also, thanks to Marcelo. I just want to clear my record. You introduced me as the senior advisor. He likes to call me the senior advisor. I'm just officially part of WHO's Digital Health and Innovations Department, and I sit as a vice chair of the focus group on AI for health management of and IT. Let me point to the question on digital health and AI and how the big data roles come into play. Digital health technologies, AI, big data, and machine learning, they all hold the promise of transforming health. I mean, we have examples of AI which can help scale healthcare services to reach the most marginalized people and advance emergency care, healthcare, universal healthcare, which can shape sort of not only just the healthcare services, but also the societies and the economies through empowering, engaging communities. During the assembly this year, the 73rd World Health Assembly, which is focused on COVID-specific topics, countries called to leverage digital health technologies for the response of COVID, including by addressing not only health, but also socio-economic impact. So I think we have to think from a very broader perspective here, not think of in our cocoon itself. Technologies like AI in the fight of COVID is used to assist with population screening. We've seen examples of tracking infection cases, monitoring resources, and more notably, define the social determinants of health, the fundamental equity and human rights elements in the fight against COVID. However, while AI and technologies like it hold huge potential for good, we must also leave space to discuss the real life ethical questions surrounding its use. We must ensure that AI is used correctly in health and care systems, particularly concerning equitable access and patient privacy. To move us forward, towards a vision for health for all that WHO has set out, or DG has set out, we have a global strategy on digital health that is coming out, which specifically calls on for benchmarking and regulating AI and digital health medical devices for implementation by member states, not just for COVID in general, but it very well applies to COVID as well. The framework will look at equitable access, interplay of AI and digital divide, education of how AI functions and make decisions, and strengthening public oversight and regulations of the private sector. Ultimately, the value of AI will depend on overcoming the digital divide. To truly reap the benefits of AI, I think equitably for the whole world, we must address the governance issues, the public trust issues, and the ethical considerations. Without proper regulations, the divide will grow, and I think the countries will, with social and ethnic disparities, will suffer more. So I think to summarize it, if we need to use AI, which has the potential to help millions of people, it should help seek affordable, appropriate, equitable healthcare worldwide. I think we need to ensure that as a community, we are leveraging and addressing those main points. I'll stop there. Thank you.
Thank you very much, Samir. And I really like how you put on the table the importance of ethics in the use of AI technology. So I will give you the floor, Marcelo, to continue with the conversation.
Thank you very much. Thank you very much, Analía and Jack. We will go back to you now. I have a question for Luis, because the idea here also of this panel is to connect, under the context presented by Dr. Espinal, experience from the Harvard Medical School that is very connected with other groups, MIT and others, WHO, the bank, and us, of course. There. So on that context, and Luis, and taking into account that the IADB is extremely engaged, not only in artificial intelligence, but in different areas working on e-government, digital transformation, digital health, etc. What will be the path to responsible and equitable? Equity was mentioned several times here. Adoption of AI for improving the delivery of health and social services, but considering the high-level vision of the UN that was adopted by all the countries of leaving no one behind. And what are the main risks? Because I know that you are very concerned about risks. So what are the main risks that you visualize here? So you have 7 minutes for that. Thank you.
Okay, thank you, Marcelo. I'll try to make good use of the time. As you know, the bank has been involved in an initiative called FAIRLAC, which is the umbrella under which we're doing most of our work in artificial intelligence in the social sector. And the way I like to think about it is in terms of safeguards. If you think about building a school, you wouldn't build a school without certain safeguards to make sure that the school is safe, right? Kids can go in and they will be they can go safely inside. They won't be contaminated with anything from the materials. So building an AI system should have not similar but equivalent safeguards that'll lower risks and make most of the opportunities artificial intelligence. And I think it's a very thin line. It's a bit of a balance that one has to make between promoting the many things, and there are many, that artificial intelligence can do in the social sector, and particularly in health, and avoiding the risks which come with a new technology, and especially when we get excited and we want to solve problems, and we want to use this technology to solve problems that have been with us for many years. Now, let me list just a couple of them, and they for sure apply to the artificial intelligence that is being developed for different areas of the fight against COVID. I would start with making sure that you have the necessary information for the training of algorithms. What does that mean? It means that you may have algorithms that are trained in a certain region or with certain equipment, but you need to make sure that those algorithms work in if you want to implement them, for example, in Latin America. There are very popular algorithms that have been trained for detecting malaria, for example, on the basis of blood sample images. But you need to be sure that the way the images were prepared is equivalent to the way the images are prepared in our region if you're going to implement one of those algorithms in our region. So it's important to make sure that not only we can use algorithms prepared elsewhere, but we also have the data that to make sure that the algorithms can work in our region. Another thing is making sure that you start from an actual problem, which is it's very important in general. In the case of COVID-19, we for sure have a problem, but we need to make sure that we are addressing a particular stage of the problem. Are we talking about changing behavior of people? What is the priority to predict the spread in a city, to have algorithms that detect early symptoms of COVID-19, etc. But we need to make sure that we're starting from the problem and not from the technology. And I'm a fan of technology. I like technology, and I know that it's tempting. It's tempting when you have something technological that works, that's something nice, to try to use it to solve problems. And you need to restrain yourself a little bit and make these safeguards that will force you to start with real problems and then think about the technology that may apply to them, that could be artificial intelligence or could be something else. But there are certainly many cases in which artificial intelligence is the answer, and I'll list some at the end. And another thing that Dr. Espinal and Analía, I think, alluded to, is that the algorithm is part of the problem. It's an important part, but certainly not all of the problem. And to those listening, I would suggest an exercise that I like to do. Think of any symptom or any disease, and go to and put the name and add artificial intelligence next to it. And I pretty much can guarantee that you'll find peer-reviewed papers that somebody published that found an algorithm that can detect it or help somehow with it. And another thing that we're doing in our initiatives is making sure that, yes, you do the algorithm, you have a good algorithm, but you have a plan to take it to areas in which you want to implement it, precisely to avoid creating inequities and to actually use the artificial intelligence to lower inequities. Are you budgeting for an implementation? Do you have the money to buy the equipment, if you need equipment, in rural areas to make use of the algorithm? Does it work with the kind of cell phones that people will use it in rural areas in Central America or in the Amazon in South America? And also algorithm audits, making sure that you're not leaving small groups behind, because if you have minorities, you may be using less data to train the algorithms, and then the algorithms may be less precise. It doesn't necessarily have to reflect existing biases, which is something that is mentioned a lot. We always talk about algorithms reflecting existing biases, and that is a problem, and it has solutions, and we need to be sure that we're not doing that. But it could be something very innocent, like just having less data for a certain group, and then less precision with the algorithm. So you need to take care that you're not doing that in order that you can implement the solutions in hard to implement areas. The solutions work, and you're not having a particular group of population excluded because you didn't have the right data. And this has been, I think, COVID, artificial intelligence for COVID has had a slow start. We saw the algorithms for predicting the outbreaks early on, and we saw some for diagnosing with chest images. And those algorithms were made public, by the way. One of the first algorithms that was made public, freely public, and was the algorithm to classify chest images. But it wasn't really practical. It hasn't been implemented at a large scale. So we need to, we're seeing a very promising initiative right now. Dr. Espinal mentioned one that they're doing at MIT with IBM with 10 of the most promising initiatives. One is, by the way, the prediction of early prediction of sepsis in hospitals, which I think is one of the most promising areas. But we do have many examples in the region of good, responsible use of AI. In Chile, the detection of diabetic retinopathy, telemedicine, and early detection of sepsis, not necessarily for COVID in Brazil. We have breast cancer in Argentina, and the selection of people for particular social programs in Costa Rica and Panama. So we do have excellent examples, but we do need to make sure that we put in place the safeguards so that nobody's left behind. And we're not doing all this exercise for people who can, you know, the richest quintile who can afford it.
Thank you very much, Luis. Extremely important. Your comments are also seconded in, if you look at the questions. So I also want to invite the panelists to take a look on the questions or comments, suggestions. I also, before passing the floor to Jack, because I want you, Jack, to comment on 3 minutes what you heard from Luis. But also I want to highlight the presence of several PAHO WHO representatives that are connected. Thank you so much. We have the PAHO WHO representative from the Caribbean, from South America, from Central America. Also, we have people from the global level. Thank you so much. So, Jack, what are your comments and your thoughts after hearing Luis right now?
So, just to clarify, Marcelo, with respect to like biases with the AI, is that something that in particular?
Yes, and also risks that you may see, for example, in particular, after you run the project, the COVID-19 simulator, that was a different perspective using artificial intelligence. What are the risks that you see?
So, yeah, one of the challenges and this is applicable to all modeling exercises, is people start very quickly seeing this as a prediction tool, as if this is prophesizing the future is going to happen. But we have to keep in mind, most of these models and tools are designed to inform policies, what if scenarios. What if I take action 1? This is the outcome this we can expect, versus if I change my outcome and it leads to action 2. So many people have seen these models as predicting what new cases would be in next 1 month or so, which is a very difficult exercise because a lot of things are changing. There are many moving parts. If we have different interventions, like how much movement is happening, how people are, if they're wearing masks, etc., all these matter. And it's very difficult to capture all these factors in any modeling exercise and predict this is what the future will be. It's like predicting weather 1 month in advance, what the weather would be like 1 month from now. So we have to keep that in mind, the moving parts, when it comes to these models. So we should use this as aids to inform decisions rather than predicting future.
Thank you.
Yeah.
Yeah, thank you. Thank you very much, Jack, because we saw that every time there is a release of a prediction or something like that, there is a huge reaction. It's like physics, the reaction from the media, from the people, and all of that. So thank you so much. Now, Samir, you are part of the global leadership team on digital health at our headquarters in Geneva. So as a member of this digital health department, congratulations that we passed yesterday, the day before yesterday, discussion with member states on a global digital health strategy. So what is your vision, and your vision reflects WHO headquarters vision on the main challenges that countries should overcome to effectively implement AI solutions for supporting public health? And I want to reinforce that, because one thing is AI solutions that are applied to medicine, but we are talking here something bigger, something that is extremely complex, because public health, under the umbrella of that, health should be across all the sectors. So what are the main challenges for the countries in adopting AI solutions for public health in general, and in particular now on the fight against the pandemic? You have 7 minutes. If you can do in 5, much better. Thank you, Sami.
I'll do it. Thanks, Marcelo. No, I think you pointed out very well, and the great comments before already indicate the technology is there. The technology is not the problem. The solutions are there. I think the problems that we're facing is the governments are not ready with the governance and the policy structures around this, and that becomes the main hindrance. I was part of helping several countries during this COVID reaction, and we saw that they were hampered with the lack of an onset of governance. What regulatory structures can we apply? Ethics was not even in the thinking. We could come out with some ethical guidance for the countries, but not having that infrastructure and not having the preparedness ahead of time was a massive hindrance as the first place. I think the second part I want to mention is the other challenge is the infrastructure. The equitable infrastructure, I think, is a very important component that the countries have to look at and highlight in terms of adaptation of AI going forward and preparing themselves for COVID. I mean, now that countries were trying to implement, as they were going through the pandemic itself, the solutions, and I think most of them had no other options. But if we are better prepared ahead of time, now that we've seen that we can get burned, we need to be well attune ourselves to standards, to interoperability options, to cross-border solutions, because the virus doesn't have any borders limitations, and to an equitable model to reach out through as simple as, I mean, the technologies need to be enabling, the countries need to be enabling these technologies to deliver to the bottom of the pyramid population, to people with dumb phones or the non-featured phones, as they are doing, because most of the discussions were around smartphones, AI algorithms at the top. We have to again remember the equitable part of it, and it's all possible. It's just that we need to prepare ourselves better in light of things. We've learned a lot of lessons. Let's look at those lessons and how we can replicate and sort of solve the issues in terms of where we failed in the past. There are still questions around contact tracing, the proximity tracking, the efficacy of that, and how it has helped. Some countries have shown that it helped them. Singapore was the first one to pick it up and said it worked for them. There were other countries which have shown that in the Nordic countries where a few of the people were using it, even if there was smart penetration, which all warrants to talk about equitable delivery. And I think the last one, which was slightly ignored because of the pandemic situation, was the ethical considerations. I think we were able to, fortunately, through WHO, come up with guidance on ethical considerations that was developed and is being employed by member states. But that's also important. If we're well prepared, I think the ethical considerations will be plugged into play much more effectively. I'll pause there, Marcelo. I think there are several lessons learned. But as just to summarize with what most of the member states said in the consultation day before yesterday, as you mentioned, it was the need to learn across now and be prepared much better for the future.
Thank you so much, Samir, and thank you very much for the great work that you are doing, leading the under the overall coordination of Mariano Bernardo, the Chief Information Officer of the World Health Organization. It's not an easy task to define global standards and global recommendations. So thank you so much. And also I want to highlight the presence of the digital health leaders across the regions. We have almost all the regions here with us. So we have a lot of questions on the chat. We have questions coming from social media, from email, from WhatsApp. So it will be impossible. We have more than 500 people connected, but we will prepare a report of this. And I want to take the last 10 minutes now making a summary, but not by myself, but also I will ask our colleague from IADB, Cristina Pombo, because the idea, and I am extremely happy, I want to pass a final message. So, two things. One is that something that I always like to reinforce with this topic of artificial intelligence, and we discussed that with Jack in one of the discussions that we had, is that people assume too fast that they understand artificial intelligence. And this is one of the biggest risks that we have. People think that, okay, because I read 2 or 3 papers, now I know what artificial intelligence is, and I know how to apply that. So this is a very big risk, and we need to understand, again, this cycle reincarnation of artificial intelligence. And I am extremely happy because at the beginning, people were anxious when we're hearing Marcos to say, okay, but let's talk about artificial intelligence. Let's talk. So extremely happy to see that. But again, the idea and the configuration of today was to put everything into the context of the response to the pandemic under the umbrella of public health interventions. And this is key. And this is why we also invited the vision from the academia, the vision from the global level, the vision from the development bank, and the vision of a particular government, the city of Buenos Aires, but from the umbrella of an international expert who can provide also a vision from a different angle. So taking that into consideration, that this is the idea for creating a framework for public health interventions based on artificial intelligence, is that I will pass the floor to Cristina Pombo, who is also the author of several publications from IADB. I want to thank also my co-moderator, Natalia, and all the great panelists that we have. So I pass the floor to you, Cristina. Thank you very much now for representing IADB in the closing remarks.
No, thank you, Marcelo, and thanks to all the panelists. It was a really great conversation. I have a lot of questions, so I'll be posting those in the chat for sure, because for Samir and for Chhatwal, I have a lot of you kept me thinking of a lot of things, so thank you. And I think, Marcelo, as you said, we might have different opinions in different areas about the role of AI in healthcare. But I think we all agree in 3 points. The first one, there is a great potential. We have new options to prevent, respond, and recover from the pandemic. And AI is one of the most relevant technologies to fight not only COVID-19, but other pandemics as well. The second one is that there are many applications for many actors: diagnosis, medical imaging, molecular structure, vaccines, spread, evolution, can be useful for doctors, scientists, and policymakers, between many others. And the third one is that we're on the right track, but we are not there yet. AI could help with the next pandemic, but not with this one. We're still behind in terms of good data, skills, capacity, and a lot of ethical considerations. So before becoming a problem solver, AI must face its own challenges. And how do we ensure that AI is used to benefit all, not only few? So I think this one should clearly be our call for action. More than 160,000 deaths in our region. We don't know when the next pandemic will come. So the best thing we can do is to be ready as soon as possible, or even as soon as impossible. So thank you very much to you all.
Thank you, Cristina. And with that, to say goodbye to all of you, I will share the screen for all of you to see the results of the survey. We have 120 people, almost 70%, majority of the people agree that the area of machine learning will be one of the more important, and then decision support platforms and chatbots. So with that in mind, also something that we are planning to do is to develop a technical guidance on this particular topic with the panelists and other experts. So we want to thank also the collaborating centers that we have. A lot of people was behind the scene. Hospital Italiano from Buenos Aires, Recaín, Servaxel, Networks, Ritmos, the University of Illinois, the US National Center for Supercomputing Applications. So there is a network of people and institutions, but as you may imagine, it's impossible to accommodate everyone here. So thank you so much. And I want to thank our department director, Sebastián García Saizó, for providing all the necessary support that we need to run this promising artificial intelligence framework for public health, and again to our keynote speaker and panelists. So with that, we will close the session. Thanks so much.